Hello, everyone, and thank you for this opportunity to talk about human papillomavirus vaccines, opportunities, and challenges. I have nothing to disclose. The goals of this presentation are to review current trends in HPV-related disease, as well as HPV vaccine safety and effectiveness, and updates to HPV vaccine recommendations. We will also cover key barriers to HPV vaccine series initiation and completion among both male and female adolescents, and then identify strategies to improve implementation of HPV vaccine recommendations. So as many of you may know, human papillomavirus is the most prevalent sexually transmitted infection. Most of us are exposed and infected at some point in our lifetime. About 8 out of 10 men and women are infected at some point, and there are 14 million new cases per year in the U.S. Important for our role as pediatricians, HPV disproportionately affects youth, and so of new infections, about 3/4 of them happen in 15 to 24-year-olds. And if you look at even younger adolescents, ages 14 to 19 years, about 1/4 of them are infected with at least one HPV type. And that's really related to the initiation of sexual activity because the risk is highest shortly after the initiation of sexual activity. And so if you look at teens, these are results on this table from a recent behavioral health survey. About half of teens by age 17, I think these numbers apply to our report that they have been ever sexually active. And there's even a small proportion that have been sexually active before the age of 13, as well as about 15% who've had multiple sexual partners. So again, as I just mentioned, HPV is acquired shortly after sexual initiation. This is even with history of just one partner. And so this graph here on this slide denotes the cumulative incidence of HPV over time from the initiation of sexual activity. And so if you see 30% of women acquire HPV by 1 year and about 50% by 3 years. And for adolescents, the median time to their first HPV exposure and infection is 3 months from sexual initiation. So this really highlights the importance of early protection for teens. So there are many types of human papillomavirus, and about 40 of those infect mucosal surfaces. So that could be a mucosal surfaces lining the anogenital or oropharyngeal tract. And about 80 types result in cutaneous infection. So these are types that may be related to kind of common hand and foot warts. It's the mucosal sites of infection that we are most concerned about. And so amongst these 40 types, there are some that are considered high risk, most commonly types 16 and 18. And so these are high risk because they have oncogenic potential and can result in a range of cancers, including cervical, anogenital, and oropharyngeal cancers. And then there are also low-risk types. And so these can cause infection and active disease, but do not have oncogenic potential. And those are the types that can cause genital warts, as well as respiratory laryngeal papillomas. So overall, even though this is a very common sexually transmitted infection, the vast majority of these infections do spontaneously resolve. But if you have persistent infection, particularly with these oncogenic types, which really means that they can begin to kind of reproduce without any controls, those are the ones that can progress to neoplastic lesions. And it can be quite difficult to predict in which, who is more likely to experience this progression. So again, there are about 130 known serotypes invading both the cutaneous and mucosal cells. And we have both genetic and epidemiologic evidence showing that HPV is a necessary cause of cervical cancer and is also strongly associated with other anogenital cancers. So when we look at HPV-associated cancers in females, cervical cancer is most common and the one that we tend to be most concerned about. And then there has been a decreasing incidence over time. These are data from, I think, about 3 or 4 years ago from the National Cancer Institute. But there are persistent disparities, sociodemographic disparities related to kind of income and race in the risk of cervical cancer disease and death. And then, as you can see, there are also several thousand cases of other types of HPV-associated cancers in females, particularly anal and vulvar cancers. And there's even an increasing incidence in these other types of cancers. When you look at HPV-associated cancers in males, because they are also at risk for cancer, oropharyngeal cancer is the kind of most prevalent outcome, and there has been a significant increase in HPV-related oropharyngeal cancers in males. In fact, there are some estimates that the incidence of oropharyngeal cancer in males may soon outstrip that of cervical cancer in females. And then anal and penile cancer are also important outcomes as well. And so while we tend to be most concerned about cancer and its associated morbidity and potential mortality, genital warts is another important outcome related to HPV. About 1 in 10 people will develop genital warts in their lifetime, and there are about 300,000 new cases per year. And when cases do occur, they can be quite difficult to treat. And so you can really have a high recurrence rate after treatment. It can also result in kind of difficult control of ongoing transmission, because you can transmit the virus when asymptomatic. And then another important outcome to consider, and this is one that is not very common, but it's really associated with significant morbidity, is that of respiratory papillomatosis. And so infants who are born to women who have active genital warts are at risk for developing this condition, in which they essentially have papillomas along their respiratory tract. And this can result in difficulty breathing and require surgical intervention to debulk those papillomas, and they tend to continue to recur throughout childhood. So for many reasons, prevention of HPV is important to prevent these potential outcomes. And we do have some prevention strategies in place, primarily Pap screening. That's been the cornerstone of prevention for cervical cancers. But Pap screening programs are not well established in many other countries, particularly low and middle income countries, and even in places like the U.S. Where we do have well-established programs, there are disparities in their kind of uptake and utilization. And then we really do not have screening programs in place for non-cervical HPV disease. And even with screening, treatment and follow-up of precancerous lesions to ensure that they don't progress is costly and associated with its own morbidity. And then other strategies like abstinence and condoms can reduce risk, but they are kind of imperfect in that you can still, especially with condom use, have transmission of HPV. And then their limited use or inconsistent use also restricts their overall population level impact. So for all of these reasons, HPV vaccination is really an important prevention tool. And so HPV vaccines they're a recombinant vaccine. And so this is similar to the way that hepatitis B vaccines are made. And so it's essentially the gene that codes for one of the outer capsule proteins of the HPV virus, which is an important capsule because this is the one that our body recognizes, and it's one to which we mount an immune response. So that gene is kind of inserted into yeast cells, and that yeast cell then makes lots of these capsule proteins that assemble into a little particle that's virus-like. So it looks just like a virus on the outside, but doesn't have the rest of the viral DNA in the inside. So it can't really cause, it's not a living virus. It just looks like one on the outside. And so it really and it produces a nice immune response because the body sees it and thinks that it's a virus. And so this is just another schematic of how the vaccine is produced. And so there have been 3 different HPV vaccines produced, as you probably are all well aware. The quadrivalent and bivalent vaccines were the first 2 that were licensed for use. The quadrivalent vaccines licensed for both females and males, and the bivalent vaccines for females alone. These initial vaccines the quadrivalent vaccines targeted type 16 and 18, accounting for about 70% of cervical cancer cases, as well as type 6 and 11, accounting for about 90% of genital warts. And then most recently in 2014, the 9-valent vaccine was approved and essentially now is supplanting the quadrivalent vaccine and is approved and now recommended for both females and males. So this is another summary of HPV vaccine composition as well as comparison, and it really just tries to highlight the kind of additional coverage that is afforded by the 9-valent vaccine. So you can see the 9-valent vaccine also includes types 6, 11, 16, and 18, as well as an additional 5 types that account for about another 15% of cervical cancer cases. And then, as you can see here, a similar proportion of other anogenital cancers, and about 5 to 9% of oropharyngeal cancers are added with these 5 additional serotypes. So it really does help broaden coverage, mostly for females, but for males as well. So next I just want to turn to changes in the HPV vaccine recommendations that we've seen over the past year or two. And so this timeline just highlights the evolution of recommendations, again, with the initial licensure of the quadrivalent vaccine that was initially recommended for routine administration to female adolescents, and then the addition of the recommendation for males. And then we, of course, have introduction of HPV-9 in 2014. And so current recommendations call for routine vaccination of all adolescents at age 11 to 12 years. Vaccination is also recommended for catch-up through age 26 for all female adolescents and young adults, and through age 21 for males if they have not been previously vaccinated. However, if you have a male who is a male who has sex with men or is immunocompromised, so that includes individuals who are HIV infected, the recommendation is to continue catch-up vaccination through age 26. And in terms of which vaccine to use, again, the 9-valent vaccine is essentially supplanting the quadrivalent vaccine, but that is can be used for both male and female adolescents. And the bivalent vaccine, which is still used in some other countries, is for females, or at least licensed here in the U.S. for females alone. So because the 9-valent vaccine was relatively recently introduced, I just wanted to go through these important points, especially if you do have teens that may have started the series with the quadrivalent vaccine and need to complete the series with the 9-valent vaccine. There is no routine recommendation for using HPV-9 amongst those teens who have completed the quadrivalent or bivalent vaccine series, nor is there a routine recommendation for additional doses if you're completing a series with the 9-valent vaccine. So if they've received their first dose with the quadrivalent vaccine, you wouldn't necessarily give extra doses with the 9-valent vaccine. And then still importantly, their recommendation is for continued routine cervical cancer screening for women ages 21 to 65 years of age. And so, even though we have an effective prevention tool that may influence the overall incidence of cervical cancer, at this point, there's no recommendation to make any changes to routine screening because there are other serotypes that are not covered by the vaccine. So the other important update to HPV vaccine recommendations is the new licensure for a 2-dose series for younger adolescents. And so for the 9-valent vaccine, shortly after the time of initial licensure, non-inferiority data and immunogenicity data was also submitted for a 2-dose series. And based upon those results, adolescents who received their first dose of HPV vaccine before age 15 years may complete a 2-dose series with a minimum of a 5-month interval between the first and second dose. The language of the recommendation is a 2-dose series at 0 and 6 to 12 months. And importantly, this is only for younger adolescents. The adolescents who received their first dose at age 15 years or older still must complete the initially recommended 3-dose series at 0, 1 to 2, and 6 months. And additionally, any adolescent who is immunocompromised at any age, regardless of their age, must also complete the 3-dose series. And that really is just to optimize their immune response to the vaccine. So why the change to a two-dose series for younger adolescents? So essentially, the multi-dose series allows for initial priming of the immune system and then a boost. And so the initial doses at 0 and 1 to 2 months those are priming doses. And so that acquaints your immune system with the HPV virus or the antigens in the HPV virus, and then it also allows for the production of memory cells, which is what we really need to confer long-lasting immunity. But those memory cells need some time to really fully mature. And so that is why we get a booster dose once those memory cells have really matured to kind of solidify long-term immunity. And so you have your prime, and then you have your booster doses. And so when trying to decide whether we still needed 2 priming doses, there was a comparison of the immune response in this 2-dose compared to a 3-dose series. And those results showed that the immune response was actually more robust in younger adolescents, and certainly at least comparable to the response to a 3-dose series. But similar results were not noted for older adolescents. So this is what supports this 2-dose schedule. It's also noteworthy that the World Health Organization has recommended a 2-dose schedule for HPV vaccines for teens younger than age 15 years of age since 2014, and this has been adopted in several countries, which has been really important for immunization programs, particularly for those in more resource-limited settings. And then the other point is that these trials comparing the 2 to 3 dose series are not, the outcome is not efficacy against infection or other clinical endpoints. It really is immune response. But the immune response with the 2-dose series is quite robust for older teens. So this can be maybe an important point to make with parents that the series can be completed with 2 doses if you start your series as recommended at age 11 to 12 years. So what about vaccine efficacy? And especially now that the HPV vaccines have been available for more than 10 years, we have more and more data in support of their impact on disease rate. So if you look at all of the pre-licensure data, so these are all from the clinical trials before vaccines were licensed, HPV vaccines demonstrated a 90 to 100% efficacy in preventing a wide range of HPV-related outcomes. And importantly, of course, do not prevent disease if you've already been infected with the vaccine type at the time of vaccination. So these are purely prophylactic vaccines. And safety data as well, just to emphasize, and we'll talk about vaccine safety again a little bit later in the presentation. The vaccines have, really do have an excellent safety profile. Of the almost 70 million doses given in the U.S. as of March 2014, there are about 25,000 reported adverse events, the vast majority of which are non-serious. So like local reactions at the place of vaccination, for example. And there have been large observational studies since vaccine licensure and vaccine safety monitoring for more than 8 years in large groups of people, looking at a wide range of outcomes that may be of concern to some parents, but things including Guillain-Barré syndrome, seizures, autoimmune disorders, and stroke and other thromboembolic events. And none of these observational studies have shown any association between the HPV vaccination and any of these outcomes. In general, serious adverse events are very rare with no increased risk amongst vaccine recipients if you compare them to people who have not received the vaccine. Outside of syncope. Syncope is really the one outcome that was found to correlate with vaccine administration. And that's really not specific to HPV vaccines, but can be seen can develop after the receipt of other adolescent vaccines as well. Turning back to vaccine effectiveness, these next couple of slides just demonstrate its impact since introduction, which can be important information, I think, to share that these vaccines really seem to be having an impact both for individuals and at the population level. That is really demonstrated nicely in this slide. So this is a study looking at genital warts in women in Australia. And this was looking at rates over time before and after vaccine introduction. So the vaccine was introduced in 2007 in Australia. And you can see kind of a steady decrease in genital warts, particularly amongst younger women, so adolescents and young women. And so these would be young women who had been more likely to be vaccinated prior to probably have exposure to HPV. So you really can see kind of a population level impact. This is overall across the population. And then these are more recent data from the US, again demonstrating both kind of individual and population level impact. And so this is a study that compared the prevalence of the quadrivalent HPV vaccine types, so that would be 6, 11, 16, and 18, and prevalence across all 14 to 19-year-olds participated in this study in the time before vaccination and before vaccine introduction and after vaccine introduction. And you can see that overall prevalence in this cohort decreased quite significantly from 11.5% to 4.3%. And there were also reductions seen in older adolescents as well. So again, there would be a higher likelihood of exposure to HPV vaccine in an older age group, but you can still see impact of vaccination overall in this group. And then the last line in this table shows HPV type prevalence amongst a group who would be at high risk for exposure. So these are sexually active 14 to 24-year-olds. And here you're comparing those who were vaccinated to those who were not vaccinated. And so the HPV type prevalence was only 2% in the vaccinated group compared to the non-vaccinated group, in which prevalence was almost 17%. So again, just demonstrating effectiveness and impact. Though of note, no significant reduction in non-vaccine type prevalence has been noted in these studies, suggesting that there probably really isn't any cross-protection. And then lastly, there's been a recently published systematic review of about 20 studies across 9 different countries to look at a population-level impact of HPV vaccination. And this review showed that in countries with more than 50% coverage, at least amongst 13 to 19-year-olds, the prevalence of types 16 and 18 decreased at least 68%. That's a pretty significant reduction. And anogenital wart prevalence also decreased significantly, showing evidence of herd immunity. This review did suggest that there might be some cross-protection against other types, even though that was not demonstrated in the study I just presented from the US. So, we have an infection, HPV, which is very common and affects most of us. It can result in some significant morbidity and mortality. We have a vaccine that is highly effective and safe and routinely recommended. And then as you can see here, despite all of that, HPV vaccine rates are low and remain low compared to other adolescent vaccines. I think these are the most recently available National Immunization Survey data showing that amongst females, rates for at least for the initiation of the series continue to hover around 60%, and completion rates are about at 40%, which is well below the 80% target, at least based upon Healthy People 2020 goals. And rates for males, while they've been steadily increasing since the routine recommendation for males, are still below 50% for initiation and about at 30% for completion. So why do we see this persistent gap in rates for HPV vaccines compared to the other routinely recommended adolescent vaccines? And I think this is multifactorial, and I like to think about it in 3 broad categories. So one is really related to access and some of the challenges of the provision of healthcare services to adolescents. Teens are less likely to have a medical home and present regularly for well care. And so there can be missed opportunities for vaccine delivery. They may be more likely just to present for acute or sick visits when they are less likely to probably receive a vaccine. This is an expensive vaccine. It's about up to $160 per dose. So, and while for the most part HPV vaccines are covered by insurance, there could be some variability in the amount of coverage. And then it can also sometimes be challenging to identify eligible patients who need the vaccine, particularly for adolescents who may not always be included in registries. The other important categories related to provider recommendation. Even though this has been a routine recommendation for some time, there is variability in how providers recommend the vaccine. The vaccine may be considered optional compared to Tdap and meningococcal vaccines. There have been some studies to show that the providers are more likely to recommend the vaccine to older adolescents rather than 11 to 12-year-olds. And even though we're learning more and more about vaccine safety and effectiveness, there could still be some questions from providers as well as parents about vaccine safety and effectiveness concerns. And then parental acceptance, of course, is the other big and important category. And so even though this vaccine has been available for now more than 10 years, there continue to be persistent and in some settings growing safety concerns. This has been particularly noteworthy in other countries, in particular Japan, for example, where there has been a large kind of a campaign against HPV vaccine due to some concerns due to safety concerns, and so much so that the Ministry of Health has removed their recommendation for HPV vaccines, and so now I think rates are close to 2% in Japan. Parents also may cite a lack of provider recommendation, and so it really can matter in terms of how we as providers talk about the vaccine. And then I think many parents may think that the HPV vaccines are important and want their child to get it eventually, but at least at the time you may begin talking about it, or when it's routinely recommended, feels that the vaccine is not yet necessary, that you would wait until your child is sexually active. And some of this could be related also to just a kind of general lack of knowledge about HPV and its high prevalence, as well as the outcomes associated with it. So how can we address some of these barriers to try to optimize HPV immunization rates for teens? So this first set of interventions is really related to access and getting patients to clinic. And a lot of this is related to some recent systematic reviews that have really tried to evaluate what works best. There really has been quite a bit of work looking at different kinds of interventions to try to improve HPV vaccination rates, and so really trying to sort out where we should focus our resources is important. So reminder recall is one important approach, especially since adolescents may be less likely to present for well care, and so there have been initiatives such as text message reminders, especially for series completion, using postcards and mailed letters, phone calls, or even outreach visits. And a review of 7 studies using some of these approaches did show a significant increase in series initiation, as well as the receipt of second and third doses. And increase in series initiation and completion range from about 6 to 16%. This little graph highlights results from one study looking at, these were text message reminders. And I think we can see what the impact of a 2-dose series for younger teens will do for series completion rates as well. There have been other more kind of physician-focused interventions, particularly leveraging clinical decision support, in which we use health information technology to support clinical decision-making at the point of care. And so that might be, if you use an electronic medical record, to have some kind of alert that appears when you open a patient's chart, letting providers know that the patient is due for a vaccine, or maybe even could provide some links to information about HPV or HPV vaccination, or immunization order sets to make it easy to incorporate ordering a vaccine in the patient visit, as well as focus patient data reports and summaries just to really provide some feedback on immunization rates for the patients that we're seeing. And the assessment and feedback program, AFIX, for providers and vaccine coordinators is another approach that has been increasingly applied, particularly for adolescents. And then also just education and training to, such as this, to provide information about HPV and HPV vaccines, to review strategies to increase immunization rates, and also provide important talking points to address concerns that parents may have. And so a systematic review of these types of physician-focused interventions shows an increase in HPV vaccination rates in almost all, 6 of 7 of these studies. I think it's also important, though, to consider that multiple strategies may be needed, depending upon which aspect of an HPV vaccination you're hoping to target. So just as an example, this was an initiative. This was a study or a trial from a few years ago in a large pediatric network, in which there was both a clinician and family-focused intervention. So for clinicians, there was decision support as well as kind of an audit, feedback, and education bundle. And then for families, there was an automated telephone reminder to remind families that their child was due for a visit or was due for a vaccine. And this is not necessarily very surprising, but the clinician intervention had the largest impact on vaccine series initiation. So kind of priming the provider to recommend the vaccine seemed to matter most for series initiation, while the telephone reminders had the largest impact on series completion, so receipt of doses 2 and 3. And so perhaps using a combination of these different interventions may be the way to be most impactful. Another important consideration is to think about what we can do to reduce missed opportunities. And so, for example, to vaccinated both sick and well visits, if otherwise indicated, because there has certainly been some work to show that the likelihood of receiving HPV vaccines is much higher in a preventative compared to an acute visit. But if teens are more likely to show up for an acute visit, we may be missing many opportunities for vaccination. And then if, as we kind of work through challenges in getting teens in for well care, it may be important to also consider alternative locations for vaccine administration to kind of meet them where they are, such as schools or even pharmacies. And so some states allow pharmacists to administer vaccines to adolescents, to use standing orders such that different providers can readily vaccinate teens when they do so. So that would maybe support having an immunization clinic as an example, rather than so that if a teen doesn't have to have a well visit scheduled in order to maybe be able to come in for HPV vaccine or to finish the series. And then optimizing the use of registries so that we all know when a teen is due. So just as an example of some of these potential strategies, so school-based immunization is one approach that has, there's been some increased focus on this in some areas. Other countries certainly do provide quite a few vaccines, particularly for adolescents in schools. And so in the U.S., this has not been as large of a focus since most primary prevention services do happen in clinics. But there is a growing number of school-based health centers. There are about 2,300 as of 2013. So that's in about less than 2% of U.S. schools. And most of them do provide primary prevention services, including immunization. And they have been associated with improved educational and health outcomes. But it can also be hard to sustain. And then there have also been some school-located vaccination clinics and a few recent studies evaluating their impact as well as acceptability of implementation. And overall acceptance seems to be high, a little bit lower for HPV amongst parents, and this may be related to their overall acceptance of HPV vaccines in general. But these are really challenged by sustainability, particularly staffing limitations and billing, really being able to bill for vaccines because we have such a varied and a payment process for either private versus public insurance, and so there could be different billing streams for vaccination. But of the very few studies that have really tried to evaluate these approaches, the 2 studies did show a significant increase in vaccine receipt in school-located adolescent vaccination clinics. So standing orders is another intervention that also mentioned, and so this authorizes nurses, pharmacists, and other appropriately trained healthcare personnel to not only assess immunization status, but then also administer vaccinations. And so this has really been an initiative promoted through the Immunization Action Coalition, who has quite a few resources to support implementation of standing orders. And so this could be an important approach for adolescent vaccination, and is also endorsed by both the ACIP as well as the Community Preventative Services Task Force. And then registries, again, an important way to track who needs to be vaccinated and what they need. And so registries are available in all states, as well as in some local jurisdictions, but their quality does vary, so it certainly helps to know a little bit about the reliability of a registry that you are going to use. But they are strongly endorsed and recommended by the Community Preventative Task Force, because they can be used to support reminder recall as well as clinical decision making at the point of care, particularly if you are going to administer in other locations besides clinics, and can also help identify coverage gaps or see if there are places to really focus your immunization outreach activities. So another important focus, I think, in addition to just what we may do in our clinical practice settings, is to consider some of the policies that support these interventions in our work. And so there are policy approaches that can help improve uptake, particularly those that might facilitate the ability of alternative locations for vaccination for adolescents, such as pharmacies, to really ensure consistent coverage for adolescent vaccines, especially for HPV, and then also just to consider consent requirements that could allow teens to be vaccinated without their parents being present, which could be especially important for receipt of the second or, if needed, third dose of HPV vaccination, or if you wanted to have an immunization clinic for teens to be able to come after school. And then also just to think about approaches like school entry requirements, which I'll get to in just a moment. So related to consent, the Society for Adolescent Medicine does have a statement about this, indicating that healthcare sites should develop procedures that could enable adolescents presenting for routine or confidential care without a parent to receive recommended vaccines, as long as this is within the legal requirements of one's state or jurisdiction. So I mentioned mandatory vaccination for school entry as another potential policy approach, and in the U.S. immunization requirements for school entry are a key part of our vaccine policy. We require every state, all 50 states require vaccines for entry at kindergarten, many for middle school, and for some for high school as well. Though in general, this has not included HPV vaccines. So since the vaccine's been licensed, many states have introduced bills to require either vaccination or vaccine funding or HPV education, but only 2 states in Washington, D.C. Actually have mandatory policies for school entry, in which vaccination is required for middle schoolers. So both Virginia and the Washington, D.C. do have liberal opt-out policies. Rhode Island's a little bit stricter, so they require vaccination and only allow medical or religious exemptions that must be submitted in person or completed by a healthcare provider. So, is the requirements kind of a good way to try to ensure vaccine uptake? And are there kind of ethical considerations In general, immunization requirements have been thought to really promote and support equity and accessibility, because when a vaccine is required, then there's going to be an obligation to ensure its availability to all students or all children. If you consider the severity and prevalence of HPV disease, that could be another reason to support a requirement to make sure that all teens have an opportunity for prevention, to share the benefit of the HPV vaccine and promote herd immunity as well. And it could also potentially strengthen a recommendation, as certainly a vaccine that's is required for school may receive a stronger recommendation from a provider, and also may be viewed as more important amongst parents. On the other hand, some who have are things that do not necessarily support a mandatory a requirement for school entry, could relate to the vaccine as being relatively, though now it's really not a new vaccine. It's been a license for more than 10 years. It's a price, so this is an expensive vaccine to require for immunization programs to try to think about how to ensure their availability on a widespread basis. HPV vaccine is not something that's transmitted in a classroom, or HPV rather is not something that's transmitted in a classroom in the same way that measles or pertussis would be. And then also, particularly for HPV vaccine, parents are more likely to want to be involved in decision making about HPV vaccine receipt. So those are things that have kind of pushed and pulled against implementation of requirements. And we'll see if more states do adopt requirements for HPV vaccine. So have mandates had an impact? Again, as I mentioned, both Washington, D.C. and Virginia have had pretty liberal exemption clauses to their requirements, and so their rates have not necessarily significantly increased. Washington, D.C. did change their exemption filing, making it a little bit stricter, and then did see a 22% point increase in series initiation. Whether that's all related to this change, there could have been other changes to their program as well, but that was one significant change, and as an increase was noted. And then rates are higher in 3 states that distribute the vaccine at no cost, but don't necessarily require vaccine for school entry, so that there may be other approaches related to access that are important. And then you could also look at a place like the United Kingdom that also has high rates, and there is no mandate, but the vaccine is free and distributed in schools, again pointing to approaches that really increase access. So other kind of population level considerations is really related to public education and awareness efforts. And so there were some Prevention and Public Health Fund grants given to 11 states to develop outreach programs focusing on HPV vaccination, which included using social media, radio or TV ads, provider education, as well as reminder recall. And the jurisdictions and states that did receive these funds showed significant increases in their HPV series initiation rates. Philadelphia, for example, has some of the highest initiation and completion rates in the country among females, and Chicago showed a almost 20% increase in 20 percentage points for both girls and boys in initiation rates. These are examples of some kind of public education and awareness efforts. You Don't Get It campaign is one that's taking place in Pennsylvania, targeting high schools, really trying to target teens, messaging for teens to provide information about all of the adolescent vaccines from using the voice of other teens. And these are just examples of some of the kind of, I guess you call it social marketing and social media interventions that were used as part of the campaign in Philadelphia. And so really trying to use imagery to try to kind of normalize the idea of teen vaccines. So putting messages on buses so that as you're going about your daily activities, you see the message that it's important for teens to be vaccinated. And you're talking about 3 for me rather than calling out HPV. And then on reminder postcards, showing pictures of happy, healthy teens, to associate vaccination with kind of health and happiness So I like to call this using social marketing principles to try to influence how vaccines are valued. So those are different kinds of population and policy, as well as clinic-focused interventions that can be used to try to address some of these barriers to HPV vaccine uptake. The final part of the talk will really just focus on communication, which is probably one of the most important ways in which we can influence HPV vaccine uptake. Multiple studies have really shown that provider recommendation is one of the most important predictors of vaccine acceptance, not just for HPV vaccine, but really for any vaccine. But certainly, especially now, as there is more and more access to information from a wide range of resources, when we give a recommendation, it may also, parents may also have received or sought out information from a wide range of resources. Some of those resources may be supportive of vaccines, and some of them may not be very supportive of vaccines, or may even communicate misinformation. So I think for this reason, our recommendation is all the more important. And so there has been some evidence to really demonstrate that a strong recommendation can drive acceptance. This is a study from a few years ago that I think has probably been shared quite extensively, in which a group of parents or group of providers was followed, and the group of the providers who used a more presumptive approach in their recommendation, so using statements like, your child is due for these vaccines for today, or your child will receive these vaccines today, versus a more participatory approach in which a provider may use language like, these are some of the recommended vaccines for your child. What do you think about getting these today? And parents whose provider used a participatory approach were significantly more likely to resist a vaccine recommendation compared to parents whose provider used a presumptive approach. And you can see here that about 26% of parents in the presumptive group or resisted the recommendation compared to 83% in the participatory group. And so for this reason, using a more presumptive and strong recommendation has been recommended as a potential approach. But we know, and I mentioned this earlier, that the strength of recommendation does vary amongst providers. And these are data from a few years ago, and targeting the strength of recommendation for adolescent females, but a strength of recommendation stronger in older teens compared to younger teens, even though the routine recommendation is for 11 to 12-year-olds. And so we're not may not uniformly make a strong recommendation. So predictors of a strong recommendation amongst providers have been demonstrated to be related to comfort discussing sex, since HPV is a sexually transmitted infection, as well as perceived hesitancy amongst parents. So some providers may anticipate that parents will be hesitant to HPV, and so may talk about it a little bit differently, or maybe reluctant to make a stronger recommendation. And then, we may have our own perceptions about the risk of a patient. Say, this 11-year-old really, I don't think that they're going to be at risk of exposure for some time, so I'm just going to wait for a couple of years before I start talking about HPV. This table below just highlights some of the other reported reasons for not discussing HPV amongst pediatricians and family practitioners, and highlighting some of these points. And so, a belief that this patient's not sexually active, patient's too young, they're already getting other vaccines at this visit, and then again expecting parents to refuse. So, this perceived hesitancy amongst parents is something that has been evaluated a little bit more closely. And so this is a nice study that looked at the kind of concordance and discordance between what a pediatrician may think think about how parents value different vaccines and what parents report. And so as you can see here, this is the value, reported value that parents place on adolescent vaccines, a range of different vaccines, including HPV. And as you can see, seem to value all of them fairly equally. Provider perceptions, as you will see, are similar for some, but not all. And so for vaccines like meningitis, hepatitis, and pertussis, the perception is about the same, that providers think that parents are going to highly value those vaccines. But providers kind of underestimate or think that the parents are less likely to value vaccines like influenza, HPV, and adolescent vaccines in general. And the difference for HPV is quite striking if you look at the score. And so we may be underestimating the value that parents place on HPV vaccine and could be missing an opportunity to really talk about the importance of including HPV vaccine along with the rest of the adolescent vaccine platform. So, the recommendation really is to make a strong recommendation and especially to really talk about HPV vaccines in the same way that you talk about the other adolescent vaccines, Tdap and meningococcal vaccine. So to talk about them in the same way and to recommend them at the same time instead of waiting to talk about HPV when teens are a little bit older. I think other important things to do is to try to personalize the discussion as much as possible and kind of emphasize the common ground that you do have, that you're both working to do what you can to really support your patients and their child's health, especially as they kind of move through adolescence and get ready for adulthood. And to really emphasize the message that HPV vaccine is cancer prevention, and this is a way to prevent an infection that almost all of us are at risk for. And then lastly, really knowing the disease and the vaccine so that you can provide information to address specific questions and concerns that parents may present. And I think having that confidence can really help support a strong recommendation. So very quickly, just to go through some of the kind of key questions that often seem to be most prevalent related to parental acceptance. So are you sure that this vaccine is safe? And I think this is an important, if you type in HPV vaccine safety, doing kind of an internet search, the last time I did this, several pages, came up sharing these stories of teens who've been, previously healthy, athletic, the top of their class, they got the HPV vaccine, and now they've, regressed. They don't want to come out of their room. They're tired all the time, and so, and stories like that circulate widely, which I think has probably led to a lot of, almost an increase in vaccine safety concerns. And then you have, even fairly widely disseminated messages against vaccine safety on media outlets. This is from the presidential election back in 2011 when one of the candidates talked about HPV vaccine safety during a debate. And so, you see these very these messages that are disseminated widely and unfortunately based upon misinformation. So what can you say when you're confronted with these questions? And I think what we can really do is just try to emphasize what we know about vaccine safety and acknowledge that yes, there are some side effects. That some teens will develop a mild fever, some will develop discomfort around the injection site, about 1 in 30, but these are all things that are self-limited, and yes, fainting or syncope is another potential outcome, and that you're going to take some steps to try to prevent that from happening. But that this is a vaccine that's also been tested for several years, and many people, before the vaccine was even licensed, tens of thousands, and since licensure, more than 1 million people, looking at a wide range of outcomes. And then also even if, talking about what you've seen in your practice, that you've vaccinated many people and have not seen, and that it's been done safely. Another question is often related to, well, how long will immunity last? So, my child, if they don't become sexually active until they're, in college, and I'm vaccinating them at age 12, how do I know that they're going to have protection when they need it most? And so, I think we will only know how long the protection lasts as long as we are able to observe people who have been vaccinated. But thus far, studies suggest the vaccine protection is long-lasting, and there's been no evidence of waning immunity. Available evidence indicates protection for at least 10 years. And there are multiple studies currently in progress to continue to monitor the duration of immunity. This vaccine is made using the same technology as hepatitis B vaccine, and the immunity to hepatitis B vaccines is thought to be long-lasting, and so one would expect a similar duration for HPV as well. Will the HPV vaccine increase sexual promiscuity? Am I giving my child a free license to do what they want? I think the bottom line is, one, to try to just really emphasize the message about HPV vaccination as cancer prevention. That's really what this vaccine is largely about, because that does resonate strongly with parents. And then also, if this really is a prominent concern, to share that there has been evidence to show that HPV vaccination has not been associated with increases in sexual activity, and there have been a couple of studies that really have looked at this, including this one highlighted here, where they look at the receipt of testing, diagnosis, and counseling services related to STIs amongst vaccinated and unvaccinated teens, and show no difference. And then you could also think about the parallel, like sex education, receiving a kind of exposure to information about sexuality and how to protect oneself against STIs does not increase the likelihood of sexual activity. And instead, also just really to emphasize that this is an opportunity for early protection, so that whenever your child becomes sexually active, they'll be protected. And then lastly, this is, HPV is only one of, many sexually transmitted infections. So, why can't we just wait until my child is a little older? I get it, HPV vaccine seems great. It will protect my child against HPV disease and cancers, and I would like them to get it someday, but not now. Again, here really emphasizing that there's really no benefit in waiting to initiate or complete the HPV vaccine series. That early vaccination now, when your child is in clinic, it'll be easier to get them back for that second dose. It really ensures protection before exposure. No matter when your child becomes sexually active, it's shortly after they become sexually active that they're at highest risk, and so. You just want to make sure that they're protected and are vaccinated before that happens. In case they don't necessarily tell you until shortly before they decide to become sexually active. And also maybe emphasize the message that HPV vaccines give stronger immune responses in younger teens. So this is the time to optimize their immune response, and also now we can say they can complete the series in two doses if they're vaccinated before the age of 15. What's the best way to communicate all of these messages? There's also been a recently published review of several studies evaluating educational interventions that unfortunately have shown little impact on HPV vaccine series initiation and modest impact on attitudes and intentions, and looked at lots of different interventions: parental education, adolescent education, using fact sheets, slides, radio, trying to frame messages in different ways. And so it can be hard to know the best way to try to disseminate this information in a way that's salient and meaningful and will influence parents' decision making. And so there's been more and more focus on ways to communicate effectively, and really may require consideration of both what and how. And so that may be through targeted messaging or motivational interviewing. And so targeted messaging, this is just an example. This is from a paper from a couple of years ago, where the idea is that you kind of think about how a parent, or what seems to influence the parent's decision making the most. So are they what you would consider complacent, so they may not appreciate the risk of HPV, for example? And so in that respect, you may want to raise awareness about how common HPV disease is, and they may respond more to a firm recommendation. You have somebody who really thinks about risks and benefits and might have more questions about vaccine safety. Really focusing on those specific concerns may be most important, and providing reliable and trustworthy information. And for other parents, it may be more related to convenience. It's just hard to get their teen into clinic, so they're not able to get them in to start the series, and this is where removing barriers to access are important. And then the other big category, of course, is confidence, and that's the hardest one to address, but that's really focused on trust. And so here I think it's just the relationship that you have with your families is most important, and I think makes it much easier to provide information in a meaningful way. So motivational interviewing is another approach that's been talked about more and more recently, evaluated. And this is really kind of an active elicitation of specific questions and concerns, and affirmation of those concerns, and then providing some kind of advice or response based upon that active elicitation and acknowledgement. And so this could be a part of a communication toolkit, but I think we're still trying to learn a little bit more about how well they may really work, and how we can effectively teach such approaches. So for implementing recommendations, I think this is what we know. We know that HPV affects just about everyone. We know that HPV vaccines are safe and effective, and they prevent cancer in both females and males. Early vaccination is key to really optimize effectiveness and to ensure protection before exposure. And we probably are going to need a multifaceted approach really to improve rates. Well, what we don't know is, so while there's growing evidence to support some interventions, we need to know a little bit more about how well other interventions work, and sustainability and generalizability could be challenging. And so the available evidence that we do have shows kind of modest effect sizes, and importantly, very few really specifically target 11 to 12-year-olds for whom the vaccine is routinely recommended. And then there's growing evidence that really using health information technology, things like text messaging, could hold quite a bit of promise, and we just need to learn a little bit more about their implementation and uptake. So these are some resources and tools to help support your recommendation related to HPV vaccination. I hope that this information has been helpful. I have several acknowledgments, and thank you so much. Yes, and please click the link below to complete the post survey. Thank you.